Our second presentation today is one that's been widely requested amongst our participants over the years. It's entitled Creating and Fostering Inclusive Work Environments to Prevent MSDs Amongst Older Workers, and it's presented by Dr. Behdin Nowrouzi-Kia from the University of Toronto Department of Occupational Science and Occupational Therapy.
Thanks very much, everybody. Good morning to you, and good afternoon, good evening. I understand that there's people here from all over the world, so thanks very much for making the time out of your day and afternoon and evening to join us today. My name is Behdin Nowrouzi-Kia. I'm an assistant professor in the Department of Occupational Science and Occupational Therapy at the University of Toronto in Toronto, Ontario, Canada. Really delighted to be here with you today and talking to you about a topic that I think is really, really important in the work context. And hopefully during this session, you kind of get a deeper understanding from a clinical discipline that I think should be heart and center to workplace health and safety. I'm sure there are some of my colleagues on the line as well in occupational therapy, and will tell you, I hopefully what I can do is tell you a little bit more about our role in this area as well, and how occupational therapists, both as clinicians and also in occupational health and safety, play an integral role as part of the interdisciplinary team. So thanks so much for having me. I'm just going to continue with my presentation. Hopefully you see the next slide. Is that okay? Yep. Okay. Great, thank you. Just making sure. So this is just some of my disclosures. I hold grants as an academic at the university. I also have some speaking fees. I'm also an employee of the University of Toronto. I hold an early career professorship in workplace mental health. I'm an affiliate scientist at a research center at University Health Network, which is one of the Toronto academic teaching hospitals, and also I'm a collaborating scientist at another one of the hospitals called CAMH, Center for Addiction and Mental Health, just so you know. I don't have any conflicts to declare with this presentation. Everything that I will be presenting to you is evidence-based or evidence-informed. So what I have presented to you, being an occupational therapist, is that I practice in an evidence-informed or an evidence-based environment, meaning that everything that I will be presenting to you has scientific evidence that's been peer-reviewed and supports the claims that I'm making. I will never make any claims that are not evidence-based, just so you know. So since I have such a wonderful and engaged audience from all corners of the globe, I want to tell you a little bit about the work that I do. I get the great privilege to be part of the Rehabilitation Sciences through Occupational Research and Engagement Lab. We're based at the Department of Occupational Science and Occupational Therapy at the University of Toronto. And our mission is to identify and assess risk, develop occupation-based interventions for preventing high-risk behaviors, optimizing function, really emphasizing function. So that's the unique contribution. Earlier on, I was telling you about why occupational therapy and occupational therapists are ideally positioned to be part of this interdisciplinary team that looks at workplace health and safety, occupational health, is that really we are experts when it comes to assessing function and also providing treatment for function. And we know this from being clinicians, is that oftentimes when we want to support workers stay at work, learn about work-in-place environments, go back to work, whatever the case might be, oftentimes the discussion is not only about symptom identification or diagnosis, but rather about how somebody does and works and engages in their workspace. So that's a lot of what we do in our lab as well. We also focus a lot on prevention, which I know is of interest here as well. So I get the great pleasure of working with such a dedicated group of individuals that include our learners from the undergraduate to graduate level, postdoctoral fellows. We have clinical learners in occupational therapy. I also have research staff that support the work that we do, and we're very grateful to all of our funders for making the work that we do possible. I heard a little bit earlier on about how, open access is an impediment sometimes to making the work that we do available available to everybody, and I think that's the way it should be. But some of these publishers take a lot of money to make that possible, thousands of dollars. So I want to recognize also the funders that allow us to put these the work that we do, and sometimes it's publicly funded money, and sometimes it's privately funded money, open so that everybody can use it and benefit society as a total. So this is just my contact information. I also have it at the end, but in case you're wanting to reach out to me, I'm very interested and open to collaborating with partners here in Toronto, Ontario, Canada, and all points beyond that. We're very keen and excited. We have collaborations with international partners from many parts of the globe, and I'd be very happy to connect with you and learn more about what you're doing and seeing if there's an opportunity for us to work together. So I have three objectives in my talk today that I like to hopefully achieve by the time we get to the Q&A section. And one is to really just explain to you who is an older worker. And there's a lot of variability and nuances, no surprise to us in the field of occupational health. And as practitioners, we know that it's never, black and white. Few things in life are. So we'll talk a little bit about who an older worker is, what's their engagement in the workplace like. We'll talk, and I think there's an appreciation in these groups, particularly around risk and hazard identification, particularly when it comes to repetitive strain injuries, cumulative trauma injuries, and so forth. We'll talk about that. And really, I'd like to finish off by developing and identifying strategies and solutions. I don't want to leave you in a situation where you're thinking, well, what can we do? What can I do for my clients, my patients, my workers, and ensuring that they're, working in a safe and optimal environment, but also maximizing their functional capacity. So we want them to be able to work at the best ability that they can for as long as they can. And I think I've got some suggestions that may help for that as well. So who is an older worker? I mean, it really varies from definition to definition. I'm based here in Canada, so naturally I'm going to look at some Canadian definitions. Typically in Canada, a worker is defined as being older, an older worker rather, as being one that's 55 years or older. That is a definition that's used pretty commonly in Canada at the provincial and federal level. The Organization for Economic Cooperation and Development uses a different definition. They use one that defines an older worker as being 50 and older. So just to give you a sense, I've actually even seen some literature from the social sciences define older workers as being 45 and older. And sometimes when I give this talk in the discussion, people are like, oh my goodness, I didn't realize I was an older worker. So just to give you that perspective, that it does vary, and it varies for many reasons. It varies because there's cultural differences, there's nuances in how people interpret rules and regulations in the jurisdiction that you're in, and given an international audience like this, naturally that it's going to vary. And I'm not going to be one to impose my cultural views on what that definition is in other contexts. And to give you a very real life example, the picture that I have on the right side of my screen is one that I took in Chennai, India in November. And in it, it has a job board on it was right next to a shopping mall entrance that I was standing by. And in it, it has different advertisements for positions that people can apply to. And in it, it has certain age limits. And I was there with some of my clinical colleagues in occupational therapy and physiotherapy, and we were visiting a particular hospital. And there we were looking, we're just looking at this sign, and I asked my colleagues who are from this region of India, like, is this typical? Is this typical for them to have the age limits? Because in Canada, this would be, a violation of the human rights code that we have in our provinces. And he said, yeah, this is nothing unusual here. They're basically saying that if you're within this age limit, you can apply. Otherwise, you can't. And if you notice that sign, it really does restrict to around 45 years of age. So older workers in this context are excluded from applying. And I did ask that question, and quite candidly, they kind of shrug their shoulders and say, we don't know. Like, we don't know what would happen if you're an older person, an older worker trying to get these types of positions. So it speaks to just the cultural values that come into defining an older worker. It is not just a statistical definition, but rather one that really varies as to where you are on the globe. So just to give a taste of what the participation of people, this is, excuse me, across the lifespan, but rather the trend, you can look at the nuances. What I like to do is just describe the trends overall. And one is that the workforce is rapidly aging. Among the OECD countries that are on this screen, you'll see that most of them are working towards an older workforce that's continuing to grow into the future. So older workers are going to be comprising more of the labor population, and that's just statistics that we are seeing since probably now 20 years. You may have heard the term the gray wave, meaning that there's an older cohort in many countries, particularly in the global north, that are trending towards this direction. Similarly, we're seeing, this is just another way of representing the data from the literature, showing that those that are 55 to 64 are comprising a larger group of the workforce. Their participant rates have gone up 68%. And the older groups, the 65 and older, have risen as well, to say that they're going up, and we're seeing more of those populations in the workforce. Clinically, I've had some workers and clients that I've had have been 75, and I've had someone who was 80 and was still working, and a client of mine. So this is not unusual. I think we're seeing more of these trends as different forces and geopolitical interactions encounter our labor force, and naturally people need to work for many different reasons. Here's just another one. I won't belabor the point, just in terms of the participation across countries. You can identify the country that you're in, and really what you're seeing is the same kinds of trends, is that we're seeing older workers increasing in terms of their participation, whether they're in the 55 to 64 age group, or now with the 65 to 69 year age group. And maybe the question that's coming to your mind, I've had this asked in the past, is, what about with retirement? Yes, I mean, as retirement ages increase and we're seeing people live longer, healthier lives into older adult lifespan, naturally this is just part of that progression, among other factors. Uh, this is just another way of representing that trend. If you look at I guess the orange line here, it's going up over time, to show that the 55 age group is increasing, and in terms of their labor force participation in Canada, and this is a trend you're seeing across many countries. So what challenges do they bring? So I've told you a little bit about who the older worker is. Now we want to talk a little bit about, what are some of the unique situations that an older worker may potentially encounter. And you might, some of them you may already know, some of them you already have in your practice, and others maybe are newer to you. And perhaps not. So, there's naturally the health issues, the physical health strains, the cognitive considerations that come with physiological aging. In addition to that, there could be cultural, socio political considerations, stigma around ageism, being overlooked, for example, for promotions, stereotypes about being less adaptable to change and innovation, being underestimated or devalued for their skills could be some of the social aspects of it. Similarly, they may also consider, from the health side, or the longer recovery times needed. Some studies are showing that older workers will tend to need longer recovery times, but they're also less likely to be injured or become ill just because of the experience they have in the workplace. So it's just interesting to kind of see the differences between them, but certainly some topics to consider. So having said that, I'm an occupational therapist. An occupational therapist practice in a way that is client or worker centric or patient centric. And what that means is that we value that the individual, the worker, is the expert of their own situation. And as a result, we also want to value their strengths So I would be remiss if I just talk about some of the potential or perceived shortcomings. But older workers have a lot of strengths to offer as well, and the literature supports that. So, for example, they come in with quite a bit of experience, and that experience is extremely valuable to workplaces for many reasons. They have diverse perspectives, they have skills, they have a strong work ethic and maturity that's often needed in work environments, particularly those where there's high rates of transition between recruitment and retention issues. They also address labor shortages where they might exist. We have this problem in Canada across many different sectors, the healthcare sector, the construction sector, and so forth, as just two examples. There's many others where we're seeing a very experienced group of workers reaching the age of retirement, and we're not getting enough of a replacement rate. And this is a significant concern in Canada and other countries as well. In addition to the other strengths that they have in terms of experience and knowledge, they also have very strong leadership skills, problem solving. They're reliable. The literature is quite consistent that they are dependable and they're patient. And also in terms of job tenure, they're more likely to be satisfied with their workplace, and they're more likely to stay at work. So that creates stability, particularly in environments where there's a lot of instability right now. I can think of the healthcare sector that's been, dealing with the COVID-19 pandemic. We're in a different transition of it, although the popular press may say otherwise. It's still going on, and having that stability and experience is extremely valuable. And it also supports the new generations of workers coming in. Those older workers that have all that wealth and experience can share that wisdom and knowledge with the newer workforce and share their expertise, as it's done in many different disciplines. If you just think about how the learning models are shared in my discipline, that's exactly what it's done. We send our clinical learners into clinical placements, or what we call fieldwork placements, and they learn from experiential learning by being under the supervision of a preceptor. And that's exactly what's going on, and many other sectors do the same in healthcare and outside of healthcare. For example, with the apprenticeship model in the construction sector in Canada as well, works very much the same way. So, what are some of the common repetitive strain injuries that you might see in this? I don't think there's anything different that you would see in other segments of the work population. This is just some examples of largely MSK and repetitive strain injuries that you would see because of the nature of the work that they do. Some studies have found, for example, that most of the RSIs have been reported to be carpal tunnel, rotator cuff, tendonitis, and so forth. So there's lots here to report, and I don't think this is terribly surprising to any of us here, but it's important to emphasize that the RSIs won't be necessarily any different than any other population. Their management might be slightly different, but we can talk about that. Physiological changes, I've talked a little bit more about this earlier on, but naturally there's some differences that come around with motor skills, with reaction time, weakening muscular strength, and decreased interactions. This is all what's deemed as being typical physiological changes with aging. This is not something that's unusual. This would be expected. So for those of you that work in clinical settings and you measure muscle strength or grip strength or reaction time, there are standards and norms for different age groups, and this would be what would be expected, or non-clinical settings as well. It's not just restricted to clinical settings. Similarly, we also have related to this is engaging in different types of activities require, in some cases, adaptations. It might also require different types of movements. So, I heard you were talking about the RULA and other measures. That can certainly be part of your repertoire. I think it also could be that, you observe the job, you look at recommendations for how things can be done differently. And this is part of the work that many of us do. So just looking at revisions to that. And how does that work like? So this points, we've talked about potentially some of the risks and some of the hazards that are in these workplaces, typical ones that you would see related to RSI, improper lifting techniques, manual materials handling, taking breaks, and so forth would be some of the solutions. So I'm going to frame my solutions naturally. I'm coming to this through an occupational science and occupational therapy lens. And oftentimes people ask me, what does that mean? Well, one way to think about it, and this is a model from occupational therapy that's now almost 30 years old, that looks at considering when you're providing, for example, strategies and solutions to mitigate RSIs in the older workforce, the person, environment, occupation. So looking at the person themselves and what their abilities are, what their strengths are, both physiologically and psychologically. Also looking at that environment. And as occupational therapists, we look at the environment very broadly. We're not just talking about the physical environment, but rather looking at the organizational culture, the interactions between workers with themselves, with bosses, with their supervisors, and so forth. And that's our environment. So it's quite broad. And we also look at the occupation. And to those, this is a term that we use in our discipline to mean essentially activities. We're not just talking about paid occupation. I know in this context we are, but for us, occupation is any type of activity that you do. So we're really looking at like self-care activities, productivity or work activities, and leisure or play activities. All of those to an occupational therapist are or occupations or activities. So we look at essentially what who the person is, the environment they're in, and essentially what is it that they're doing. And you'll notice that when these three circles converge, um, we talk about this term called occupational performance and participation. And occupational performance really means augmenting and maximizing function. And in our case, when we're looking at work function, we're really looking at maximizing the person's ability so that their functioning is top as high as possible. And that's important for many reasons, right? They can perform their tasks better, they can provide better care, things can be done more safely, it can mitigate injury or illness. So there's lots of reasons why this model could be used, and it's very intuitive, and that's why I use this model, particularly talking to an interdisciplinary audience, is that people can quickly ascertain what I'm talking about. Similarly, I mean, I'd be remiss if I didn't talk about the ICF. I think many of you already know this coming from your previous training, but I think it's important because the World Health Organization endorses the ICF. It's been around for more than 20 years now. It is a biopsychosocial approach, and similar like the PEO model that I just presented, it recognizes that function is paramount to health and well-being. And the reason why function is paramount, you just only have to look at the term activities. It is, what is the person doing that matters. And from a clinician's perspective, this is exactly what I do when I look at functioning in stay at work, return to work, hazard identification, risk mitigation, and so forth, is that what is the person doing, and then kind of put the other pieces together. Look at the biological functioning and the physiology, and definitely that's important, but it's certainly not the whole picture. And the WHO has identified this, and many of us as healthcare providers and occupational health and safety practitioners know this too, that health conditions are part of this the consideration, but they aren't the entire picture. And then looking at what the person will engage in, looking at the environmental factors and the personal factors. So very similar to the PEO in that regard, but really espousing a biopsychosocial lens to what we do. So having put, hopefully what I've done so far is primed you into thinking about using these two approaches to kind of looking at how we can engage to provide supports for older workers. So naturally, we're not just looking at the physiological aspects of repetitive strain injury, which is important. There's lots of considerations around that, and I know that you know these very well. So for example, conservative management, surgical management, these are all still within our toolbox, but to also value that we want to look at this through a biopsychosocial lens. So looking at the psychosocial work environment, looking at the organizational work environment, and valuing what the occupational health psychology literature has been telling us for over 40 years around job control, engagement, and so forth. So just some of the aspects around prevention. I'm not going to spend too much time on this. I debated putting this slide in or not, but I thought that if I didn't include it, people will say, well, what about these considerations? And I know that this audience is quite well informed in these areas, so I'm just going to briefly talk about some of these as part of the solutions, but that would be helpful in looking at the older worker, just like any other worker. So engineering controls, administrative changes, PPE, and safety are also important. And there's lots of literature, as we know, to support all of these office ergonomic techniques. I'm sure those of you on the ergonomic side know this inside out. And these are just some examples as to what can be done in the in the office environment, but certainly not just office ergonomics. We know there's other considerations on the physical side, cognitive system, etc., that we could look at as well. Similarly, on the administrative changes as to adjusting how people work, their work pace, workflow, the work schedules, job rotation. There's a bounty of literature to show that this works in many different types of settings as well. And then finally, PPE. I mean, when I speak to engaged and learned audiences like yours and you, we often talk about PPE, and everybody knows what PPE is now. Before the pandemic, may have to said what PPE stood for, but now because of the pandemic, we all know that. So naturally, PPE is going to be our friend as well in mitigating injury and ensuring that people work safely as well. But in addition to that, there's also other types of considerations to look at potentially conducting assessments. And some of you on the ergonomic side do this as well. Certainly, occupational therapists do this too. We may come to it from a different perspective, but I think ultimately what we're all trying to do is improve the health and well-being of our workers. And then looking at training programs, there's also health initiatives. I recognize that on this slide, I'm really looking at the emphasis on the individual, and that's quite deliberate to say that the individual worker, the older worker, has a role to play in this as well. So they do have to take care of their health. They do have to engage with the workplace and the occupational health professionals and practitioners that are going to be working with them. And they do have a responsibility, but it's a shared responsibility, and I'll get to that in a moment. This is just a plethora of the examples of literature that supports the role of ergonomics, injury mitigation in providing solutions. I'm not going to go into all of this detail. If you're interested, you can look up some of these papers. I also have them all in my reference list, so you can pull them up and read them. I just don't have the time to go through all of them today. Similarly, some of the recommendations I've talked about wellness and so forth, but I wanted to put them out there for the individual level, recognizing that there's a part for the worker to play, and we can certainly, as practitioners, facilitate and play our part in that. In addition to that, I wanted to also look at the macro picture, like a bird's eye view, and see how the other actors that are involved in supporting workers, older workers in particular, stay at work, prevent injuries, be informed in their practice, and to essentially be living and working as healthy as possible. And some of these standards you may already know. You know that Canada was at the vanguard of developing the CSA Z1003 standard in 2013. It's the first of its kind in the world, a voluntary standard that looked at psychological health and well-being. And really emphasizes both the need for understanding the psychological well-being in the workplace, but also the fact that our health is intimately tied together between the physical and the mental health. So if we're talking about RSIs, we could certainly intervene and look at positioning, look at identification of hazards, poor posture. We can talk about treatments, maybe, developing an orthoses, recommending surgical intervention and so forth. But all of that would be remiss if we didn't also talk about the policy level changes and standards that are available. Similarly, in 2021, Canada, again, as part of, and also the CSA group as part of this occupational health and safety suite, looked at the development and developed the work disability management standard system. So this one's also particularly helpful, again, looking at the older worker and how they engage in work, and looking specifically at repetitive strain injuries. What are the recommendations for keeping people healthy at work? And these beautifully can be applied to all different types of work environments and settings. So whether you're an occupational health and safety practitioner talking to a client that's working for a small business in Northern Ontario, or somebody who is working at a large financial institution in a large urban center in Hamilton or Ottawa, these principles are very similar. I'm a little bit also naturally biased in that I do have a healthcare background, so there is a great opportunity for healthcare practitioners to look at the standard and the annexes that are there. Specifically, Annex B has the role for health professionals and what they can do in this context. What is our role for supporting older workers in ensuring that they prevent getting hurt in the workplace or become ill in the workplace, particularly when it comes to managing repetitive strain injuries? How can we support them? What's our interaction like with the other stakeholders, the human resources, the supervisors, and the coworkers, and how do we do that? And the standard really lays out a nice way of looking at that as well. Similarly, I also want to tell you a little bit about another initiative that's going on right now. It's a project that's called ECHO Occupational Environmental Medicine. I think some of you may have already been on the call or joined ECHO, but I wanted to let you know this is an initiative that's hosted at the Institute for Work and Health, and it's funded by the Workplace Safety and Insurance Board. Yes, I see some hearts, absolutely. And this could be another way that we could support older workers. So, if you've got an interesting case, or you've got a question or some complexities with someone that you're working with and you need some help, you can certainly bring this to our ECHO program. And the model for ECHO, I'll just speak a little bit about it and why I think it's a helpful strategy for addressing RSIs and older workers, is that it's about a 90-minute session. And in the 90-minute session, you have two components. There's a didactic lecture that's provided by what the ECHO model calls an expert hub. This is somebody who has expertise in a certain area: occupational medicine, occupational therapy, occupational nursing, occupational psychiatry, for example. And someone gives a talk on that. And the second half of the session is an occupational health and safety practitioner, a healthcare provider, who's got a challenging case or has some questions about a client they're working with, and they bring that, and then we have a very fulsome discussion. We ask clarifying questions, and then we provide recommendations. And at the end, what's really nice about it is that that person who presented the case gets a record of the recommendations, and they can use that with their client, or with their patient, or their worker. And many times, the worker is quite enthused that somebody's going to be presenting this case and getting many other brilliant and bright people like yourselves here today as part of the echo chamber to kind of come together and come up with strategies and solutions. So that's just one other way that this can be done. If you're interested in this or other echoes, the echo model has been around for over 20 years. It started at the University of New Mexico in the United States, and it's amplified all over the place. This is the first echo of its kind in Canada, specifically, and the first of its kind in Canada, looking at occupational environmental medicine. So anything related to work and health is definitely the place to bring it. I think I'm going to stop there on my contact page in case you have any questions for me. I'd like to leave ample time for questions. I think I've spent plenty of time telling you a little bit about this topic, and I hope I did it some justice and informed you a little bit about what it's like to be an older worker, what are some of the challenges that they encounter in the workplace, and hopefully some of the solutions and strategies that we can implement together, working as part of interdisciplinary teams, transdisciplinary teams, to make sure that they're working safely, they're healthy, and that they can maximize their functioning. So I'll stop right there.
That's awesome. Thank you so much. I was listening to your presentation and I came to the realization that on your definition, I am officially going to be an older worker this summer.
Mm-hmm.
That kind of was a bit of a slap in the face. And the other comment I had was, I find it really interesting because, part of my my role at OCal is also determining the work relatedness of compensation claims. And all too often, I actually see your claim is denied because of blank age related. Yet nowhere is there any data or comparison saying at this age you would expect to see sort of this level of change, etc. So I often find that they use age as just a blanket statement to just deny a claim or something, which there's no real response to that because there is no magic number from what I've seen in my research, unless you've come across something that says at this age your body should look like this.
No, I don't think so. I've not seen that. And that's why that slide that I had about the poster, the placard in Chennai was so interesting to me because they were very restrictive, and I thought maybe they knew something we didn't. But no, I mean, as far as I know, there's no literature that defines these ages in very discrete categories. So I agree with you. I think that if anything, it's not definitely based on the evidence.
Yeah, no, I mean, I've even had like a 40-year-old worker and said, "Oh, your back claim is denied because you have age-related DDD."
Hmm.
Well, I mean, their back was completely shot, and at 40, and what you expect to see maybe at a 90-year-old, you know what I mean? It
Yeah,
just makes a lot of sense to me.
absolutely.
Yeah, Melissa, any questions in the chat at all?
Yeah, there is one question. Can you speak to the possible inherent fear of older workers speaking up about discomfort or concern to address their needs and or fear addressing issues through use of adaptation that might automate part of the job task and their worry about losing their job?
Okay, I'm just going to read that again. That's quite a okay. Thanks, Jennifer, for um, the question. If I've understood your question, I think you're really getting at the heart of, disclosure and telling the workplace that, if there's an issue that they may have, and because of them being, let's say in this case, an older worker, what are some of the potential repercussions or consequences of asking for this adaptation? Yeah, I think it's very real. I mean, this is something that the literature has written about, particularly around disclosures of different health conditions. There's bodies of literature to support your claim that those fears are quite substantial and real, particularly around asking for accommodations or even just disclosing a diagnosis. So I think that we have to, as occupational health and safety practitioners, we have a role here to play, which is really to and both educate our clients as to what their potential responsibilities and rights are, but also to advocate for them as well. In a situation like this, I would say advocacy could be a very strong tool to ensure that when we're having these discussions and someone is comfortable to, for example, or is ready to ask for work accommodations, assuming the other factors are, in line, like for example, having the claim and so forth, if it's a workers' compensation claim, as an example, that the employer or the organization where this accommodation, for example, is being requested by, understands what their legal requirements are, for example, here in Ontario, Canada, around that. And then we have a fulsome discussion. I find just, again, I'm not speaking from the research from this, I'm speaking more as a clinician. I find that when you have these conversations and these natural touch points regularly, you can oftentimes break down some of these perceived barriers and decrease the apprehension and fears, particularly that a worker could have, and in this case, an older worker, and they're legitimate. I'm certainly not minimizing or being tone deaf to their concerns, but rather that communication can be key, and so can being up to date on what the rights and regulations and the legislation say, and at the same time really acting as an advocate and being an ally to them. So I think this speaks to more of the the social aspects of supporting someone in the workplace, and that can be a huge determinant, as we know, working in this space. I hope is that helpful in answering your question, Jennifer? You can of course put it in the chat to let me know. I hope it is. The next question. Can I just read these questions? Is that okay? I don't mean to take over
Does
the
that work?
moderator's role.
If that works best for you, that's
Yeah. Okay.
completely fine. They're kind of
Sure.
sequentially there, so.
Yeah, sure. And then Tracy asked, have you also done any research on the specific issues related to older women related to menopause? No, I have not done research in that area myself. I don't know that space very well. My suspicions are that there's probably naturally, because of the physiological changes that come with aging, and also sex and gender differences that I didn't really get a chance to talk about in the lecture today. I think that's quite considerably an area of interest, not only for research, but also for us as practitioners to explore further. I actually think it would be an excellent idea to look further. I think there probably is some literature, but I don't know it well enough to be able to speak to you and provide you with more details. My suggestion here might be that if you're interested, please reach out to me. My contact information is there. I'm happy to look it up for you and tell you what I can find, because one of the, unless you have access to this, we have access to the databases that we get through the university, and I'm happy to send you what I find, and you can then we can continue the discussion, Tracy. Okay. Yeah, and let me know if that's okay, Tracy. Feel free to contact me if you like. Matt is asking, in addition to the older worker, given the inclusion of workers living with disabilities in workplaces via AODA, ACA, ADA, any tools we use to assess needs to take the functional needs of these persons into consideration, especially given that most assessments do not have the population as part of their normative data source? That's an excellent question, Matt. I agree with you. I think most of the normative data, unfortunately, doesn't specifically look at older workers, and this is an area that we need way more research on, and some of my colleagues are doing this type of work to get normative data, for example, on older workers, those that are 55 and older in the construction sector, and they're collecting that data as we speak. Specifically related to older normative data, I don't know of anything that's specific to that. In terms of any tools to assess their functional needs, definitely there are lots out there. You can look at job demands analysis would be an excellent way to do it qualitatively, and to marry both the the physical demands with the cognitive demands with the sensory demands, and look at that. So that's one way of doing it. There's also other evaluations or assessments that people like me in occupational therapy and other disciplines do, called functional capacity evaluations, functional abilities evaluations. They're sometimes deemed the gold standard, but they also have their shortcomings. They're also quite expensive, and but they give you a baseline of the functional capacities of an individual, although many of these are done in lab settings or controlled clinic environments. So they do have their shortcomings, but those are just two examples that you can evaluate function objectively. Naturally, there's also subjective measures or self-reported measures that you could look at more on a goals-based evaluation. The one that comes to my mind, and my OT colleagues in the room will probably agree, the Canadian Occupational Performance Measure is also one that looks at identifying worker goals and then working on those goals. And oftentimes you can steer the direction in this way, or I find that most individuals will report functional goals that they want to work on, and then you can use subjective scales that are self-reported in terms of satisfaction with reaching that goal and what they need to reach that goal. So there's just three examples that I think might be worthy to explore: the JDA, FAE, FCE, and the Canadian Occupational Performance Measure, or the COPM. I hope that's helpful, Matt. And if you want to reach out to me, I'm happy to give you those more in-depth details and give you even more tools, because this is part of what we teach our OT learners as well, about evaluating function in some of their courses. So I'm happy to share my resources with you. Jeanette says, excellent presentation. Thank you for the kind words. My husband cycled across Canada at the age of 64 from Newfoundland to Victoria, BC. Just saying, he then came out of retirement because he was bored at home and got a job at the grocery store. I think a lot of aging workers ignore symptoms because they think it's just too old to, it's just old age too, and so they ignore them and they need to be seen. I agree with you 100%. I mean, I think you're if you didn't know it, you're also an occupational therapist, because really the essence of our field is that people engaging in meaningful activities or occupations is beneficial to their health. And we know this in the work context for decades now. There was seminal work that came out in 2006 by Wadden and Burton, and they really looked at the relationship between work and health. and demonstrated that. And there's many systematic reviews and knowledge syntheses papers after that have shown that there's a benefit to engaging in activity. So if you're an older worker and you want to remain healthy and productive, there is benefits to engaging in occupations or in activities. And some of those occupations could be sustaining work and keeping some sort of job. I know countless examples through my clinical interactions and all just anecdotally of people that have continued to do exactly what your partner has done, which is and it really does benefit our health and well-being. It gives us a sense of purpose, pride, financial stability, and many other reasons. And the Canadian Public Health Agency has identified work as a social determinant of health. So it's part of what we all should be doing is to remain engaged in activities that are meaningful to us. So work is one of them, and I highly recommend it. Thanks for the comment. Sue says, excellent presentation. Thank you for the kind words. Yes, Peter Smith at IBS has done some terrific work on sex and gender. Absolutely, yes, for sure. Peter Smith has done some great work. I know he held a CIHR gender and sex a chair, and there are many others as well that have explored the sex and gender analysis and that work. And it's an area that we need to do more on, to look at the differences between across all the gender expressions, and to use our EDI focus, despite some of the geopolitical changes in other jurisdictions, to maximize and leverage how we can support older workers. So I think this is an area that my lab is very proud to explore. We're doing quite a bit of this, looking at sex and gender-based differences in the construction sector, and also in the healthcare sector. So if you're interested, please visit our lab and take a look at that, and look at our EDI statement. We're very proud of it. And I agree with you, and I think the great work that's being done by the Institute for Work and Health with Peter and others as well. Thank you for that comment, Sue. Laura says, how to overcome the common habit people have of thinking it won't happen to me. I guess I'm speaking out of turn here, but just speaking to you as an OT, as an academic, I would say it can happen to anybody, and that we should ensure that we play our part to ensure we're working safely and being healthy as much as possible. So all of the things that we know already, the applehood and apple pie business about exercising, good diet, appropriate sleep hygiene, all of that will improve so that it doesn't happen to you, or is less likely to happen to you. I mean, you can't definitely say it never happened to you, but that's what I would suggest espousing to. And honestly, I would say with any of these types of discussions, notice, be in an environment where you can say that what you do to work safely, whether you're an older worker or a younger worker or any type of activity you're engaging in, it's a shared responsibility in the workplace. So the workplace itself also has a responsibility, and great workplaces will emulate that with how they practice and how they do their work. And the literature is very clear on that, both from the standards that I share, the other work that's being published by organizations that are in the work and health space like CROSH, IWH, CREOD, CRE-MSD, and many others across Canada that are showing the same types of relationships. So I hope that's helpful to you, Laura. Thanks very much. Ernesto says, thank you very much for the presentation. You're welcome. Thanks for the kind words. As ergonomist, my vision is that workplace, and regardless of age, should be built risk-free. Absolutely, I agree with you. I mean, we want to ensure that there are no workplace injuries occurring in the workplace, and that's exactly where the focus on prevention is so key. And that's where I see all of us working together. So naturally, OCAL is focused on some of these types of initiatives, including prevention. And I think that as ergonomists, I'd be very happy to see occupational therapy continue to work with you and to expand our collaboration together, because we can both learn from one another. And at the end of the day, we're here to serve our communities and our workers. So I think if we can work together, we can ensure that nobody gets ill or hurt at work, and that's our goal. Gina, good information on the menopause. Okay, so there's some resources being shared. Great, the community is expanding. Mirza says, how the injuries at workplace are due to wet, slippery, snowy, and dark conditions in our environment can aggravate the MSDs related to issues. Is there any way to fast track the diagnosis of treatment of workers? how can they? I mean, those are all potential hazards that are in the workplace, so they can all lead to potential MSDs. So I would say, mitigating against those hazards might be one way to address that. We did a study maybe now close to 10 years ago, where we looked at prevention. It was funded by the Ministry of Labor, and we looked at exactly what you just identified as being hazard identification and mitigating those risks, so that we can ensure that workplaces are safer. In that case, we were looking specifically at traumatic brain injury in the workplace, but that could be one way. The second part of your question, I'm not sure I can answer that. I'm not sure how we would expedite that. I suppose continuing to work with the WSIB, identifying issues that are related to communication. We just recently published a paper. I'll put the link in the chat momentarily, where we use the Echo OEM findings from our members and looked at issues that our practitioners in occupational health and safety had, and many of them talked about communication, understanding the roles of different practitioners. So that paper might at least help you think about the second part of your question around the diagnosis. I hope that's helpful. Let me just pull up the paper. Bear with me, folks. Yeah, and I'll
While you're
put
doing
that here.
that, I just
Yeah,
want to
go
give a
for it.
reminder to everyone that's still with us to complete the Slido survey for the post session of our day for today.
Yeah, thank you. So I just put the link in the chat for you as well. So Anita, great presentation. Thanks for the kind words. You mentioned the different reasons for older workers may want to work and stay at work. Many can be reluctant and want accommodations, but how might you address issues where the employer may feel that an older worker can no longer do their work and may not be supportive of working for alternatives? Yeah, I mean, again, this comes to great question, Anita, and this can be, this potentially could be a sticky situation, but one where having conversations and being open and honest about what the work duties are, and ensuring if the person can meet those duties, and if they can't, depending on the workplace, it's very difficult for me to give you a general answer, but depending on the workplace, there could be accommodations that can be provided, and if that fulfills the need and the worker is able to do that work, I don't see if there's any issues. But if we get to a situation where they still are seeing that they're not meeting their job duties, they're not providing the level that is required for that work and the demands, then probably a bigger discussion needs to be had around modified work or duties that might be required, because we have to also balance this with, at least here in Ontario, where I would provide comments around the duty to accommodate. So it gets a bit thorny. As a healthcare provider, I can make recommendations around restrictions, limitations, but at the end of the day, it's the workplace itself that's providing those accommodations. So we can play the advocacy and the ally role, but it's going to require cooperation from many different stakeholders, including the workplace. Okay. Oh, shoot. I view message. What happened here? Okay. Thank you so much for that, sir. Yes. I lost where we were. Okay. Okay. Yeah. Sorry, Anita. Val can't help mentioning OCal has a comprehensive JDA multifactorial. Okay, great. So you have the tool there. I know IWH has done some work on that, and there's many others as well that you can take a look at for JDA work. Great presentation, Anil. Any studies related to the benefits of mindfulness meditation on work performance? I can't think of anything offhand, Anil. But again, this is one of those types of questions. If you'd like me to look into it, I'm happy to share with you. I know that there is. Our group has used the yoga as an intervention to support workplace mental health and return to work. And so that might be something that, and we've shown some preliminary data to show its effectiveness in some work contexts, but it's definitely preliminary. And Anil, in 2023, we published a systematic review and meta-analysis looking at interventions to support return to work for those that were with a mental health claim. And we looked at that literature. So that paper is available. I'm happy to put it in the chat later on if you want, or you can email me and I can give you that detail. Lily, great presentation. Thanks for the kind words. Where do you see learning styles fit into the conducting of all these evaluations? I'm not sure what you mean by learning styles. Maybe if you want to clarify it in the comments, I can give a better answer. Otherwise, I don't want to go down a path that didn't make sense or I didn't understand your question. So I'll come back to you, Lily, if that's okay. Sunita says, great presentation. Thanks very much. Presentation skills. Sure. Yeah, thank you. A lot of the great info to suggest for sure. You might be drinking out of a fire hose with the amount of information I gave you in 35 minutes. So I apologize for that. It's the nature of these types of conversations that we have. I have a role to play in disseminating information, but if you want to continue the conversation in a different manner, please reach out to me. I'm happy to connect with you. Some other comments around that. Thank you, Lori. Kavita, thank you very much. Appreciate it. There's some links from the chat. Very interesting presentation. Kathy White, thank you. I appreciate the information about menopause. Okay. Taboo topic. Yeah, it certainly shouldn't be a taboo topic. CIHR is extensive support for sex and gender-based research. So I think that should not be no longer the case. At least grants that are funded all have to have a sex and gender-based consideration in their work. Sue says, hope you come to present at the annual CAOT conference. Love to. Yeah, for sure. I'd love to do that. Thanks very much, Sue. And at CAOT or other points, maybe at OSAT as well. The Ontario Society of Occupational Therapists Conference in October. Does indoor air quality make a difference? Laura, I don't know. That's not really something that I have expertise on, so I wouldn't be able to give you meaningful insights on. Probably you need to have an occupational hygienist talk about that one. No, the volume. Okay. And I think that's it, right? I think I've addressed most, and I'll put that link to the paper that I was referring to in case anybody wants it, and it's open access as well.
Great. Well, listen, thank you so much. It was a great presentation. A lot of interest generated, some great discussion and conversations happening in the chat as well. And I just want to remind everyone that next week is our final of the 4 webinar series. We're looking at visual ergonomics, the relationship between vision and office ergonomics, and then a review of the quick exposure QEC checklist as well. And again, a reminder for those that haven't done it yet to please complete the Slido survey. And with that, thank you very much for being here with us today. Great presentation, great discussion again. And please come back in any other year to keep going with this topic, because I think it's one where there's still so much more to ask and learn about that we haven't even touched on yet.
Thank you for having me, and thanks everyone for your engagement and your wonderful comments and questions.
And we hope to see everyone again next week.